Hello, everyone. This is Kristen Robinson with the Coding Corner. Tonight, we are going to be going over the evaluation and management guidelines for MDM versus time. And if you do not know me, I am the founder and educator for the Coding Corner. I have a group on Facebook and this YouTube channel. Be sure to subscribe and hit that bell to be notified when I go live in the future or upload new videos. I am a CPC, CPMA, CCC, and a CRC. So first we're going to go into note structure. We have the history and examination, and this is for evaluation and management codes that have levels of service, including a medically appropriate history and or physical examination when performed. Now, this does differ from previous guidelines, the 95-97, that if you've been around a while in the coding world, you will know that we used to use a point system for evaluation and management services, and now you only have to review what the provider feels is medically appropriate for the history and exam. So next we have the nature and extent of the history and physical exam. Remember, this is determined by the treating physician or the other qualified healthcare professional that is reporting the service. This is not counted towards the final code that you will choose for the evaluation and management service. The care team may collect information, and the patient or caregiver may supply information directly, for instance, by the electronic health record or EHR portal or questionnaire that is reviewed by the reporting physician or other qualified healthcare professional. The extent of the history and physical examination is not an element in the section of the level of these evaluation and management service codes. You'll hear me reference evaluation and management as E&M throughout the presentation, just as a heads up. Okay, so now we're going to get into the history. The history is the interview with the patient. The only requirement now is that they communicate what is pertinent, relevant, and communicates the complexity or lack of complexity on that encounter for today. So you still want to see a chief complaint. You still want to see a synopsis of what's going on with the patient, what brought them in today, what they're needing to be seen or addressed. So the description of the patient's problem, what is their issue? Are they coming in for a well visit, which we won't be addressing well care services this evening? These are going to be your other evaluation and management services that are specifically based on medical decision making or time. Okay, so now let's talk about the level of service. So you'll be selecting the appropriate level of evaluation and management services based on the following elements. Number one, the level of the MDM as defined for each service or the total time for the E&M service performed on the date of the encounter. Within each category or subcategory of E&M services, based on MDM or time, there are 3 to 5 levels of E&M services that are available for reporting purposes. Levels of E&M services are not interchangeable amongst the different categories or subcategories of service. For example, the first level of evaluation and management services in the subcategory of an office visit, new patient, does not have the same definition as the first level of E&M services in the subcategory for an office visit for an established patient. Each level of E&M service may be used by all physicians or other qualified healthcare professionals. And if you are new to this career, just a little bit of background, you know that a new patient is a patient that's not been seen by that provider in that specialty within the last 3 years. Established would, of course, mean seen by that provider or another provider within that specialty and group within the last 3 years. So now let's get into selecting our level. So there's 4 types of medical decision making that is recognized. So if you see the table on the left, you'll see that we have straightforward, low, moderate, and high. The concept of the level for medical decision making does not apply to 99211 or 99281 because the provider is not required to be part of that face-to-face encounter. Medical decision making includes establishing diagnoses, assessing the status of a condition, and or selecting a management option. Medical decision making is defined by 3 elements. Okay, so let's dive deeper into medical decision making. Number and complexity of problems addressed at the encounter, the amount and or complexity of data to be reviewed and analyzed, and the risk of complications and or morbidity and mortality of patient management. These are going to be the elements that you are going to use from the MDM table. I do have an attached MDM format from the AMA guidelines. You are welcome to pull that off their website. I think it's a great visual for how to count your medical decision making, and in my opinion it is the best format, but there are many formats out there as long as you are following the updated 2023 guidelines. Okay, so like I said, here is a screenshot of the medical decision making table. It has your codes to the far left, the level of medical decision making. It has your number of complexity of problems addressed. It has your data column, and then it has your risk column. And each of these equate to the 4 types that we discussed: straightforward, low, moderate, and high. Okay, number and complexity of problems addressed. If you have been in this field for a while or you're currently working in a coding position, most of the time you'll see this be referenced as COPA, COPA, for the complexity of problems addressed. So one element is used in selecting the level of service is the number and complexity of problems that are addressed at the encounter. Multiple new or established conditions may be addressed at the same time, and they have an effect on the final medical decision making. Symptoms may cluster around a specific diagnosis, and each symptom is not necessarily unique to that specific condition. Comorbidities and underlying diseases in and of themselves are not considered in selecting a level of E&M service unless they are addressed and their presence increases the amount and or complexity of data to be reviewed and analyzed, or the risk of complications with the morbidity and mortality of patient management. And what this is saying is that the patient being seen may have a laundry list of chronic diagnoses that they are followed by many providers from. But in this particular instance, this specific provider is only seeing them for, say, 4 or 5 of these with a comorbidity of a couple different chronic diseases. So all of those other chronic conditions or other even acute conditions that patient may have, if they do not directly pertain to what that provider is seeing the patient for, whether that be the concern that they're being seen for today, or if it has effect on the condition they're being seen for today. So let's get a little bit further into our COPA. Okay, final diagnosis for a condition does not in and of itself determine the complexity of risk, as extensive evaluation may be required to reach the conclusion that signs or symptoms do not represent a highly morbid condition. Therefore, presenting symptoms that are likely to represent a highly morbid condition may drive the MDM even when the ultimate diagnosis is not highly morbid. The evaluation and or treatment should be consistent with the likely nature of the condition. Multiple problems of a lower severity may, in the aggregate, create a higher risk due to interaction. So what this is saying is that, let's say a patient comes in for severe abdominal pain, and the provider has to run a whole set of labs. They do an X-ray, a CT, an MRI, something like that, especially when they're coming into the ER or into a facility situation. And that provider doesn't know what's going on with the patient yet. So they've got to do all this data to find out the ultimate diagnosis. Now, you can't use your non-definitive diagnoses. So if it's rule out or possible or probable, you can't use that, but you can apply the amount of data that they used to find that final diagnosis. So if they come in for that severe abdominal pain and the provider thinks that they may have appendicitis or something like that, but they end up just having symptoms of abdominal pain, nausea, vomiting, things of that nature, with no definitive diagnosis, you still can get a higher level because of the amount of work that the provider did to ultimately rule out the diagnosis for the appendicitis. Okay, so problems addressed, defined. So the problem addressed is a problem that is managed when it is evaluated or treated at the encounter by the physician or other qualified healthcare professional reporting this service. This includes consideration of further testing or treatment that may not be elected by virtue of risk or benefit analysis, or patient, parent, guardian, or surrogate choice. Notation in the patient's medical record that another professional is managing the problem without additional assessment or care coordination documented does not qualify as being addressed or managed by the physician or other qualified healthcare professional reporting the service. Referral without evaluation by history, exam, or diagnostic study or studies, or consideration of treatment does not qualify as being addressed or managed by the physician or other qualified healthcare professional reporting the service. For hospital inpatient and observation services, the problem addressed is the problem status on the date of the encounter, which may be significantly different than on admission. It is the problem being managed or co-managed by the reporting physician or other qualified healthcare professional and may not be the cause of the admission or continued stay. So what that means is a patient could come in with sepsis on admission, and by the fifth or sixth day of treatment while they're in the hospital, the sepsis could be resolved. So they may not any longer be seeing them for the sepsis diagnosis because it's resolved. You're no longer going to code it once they have documented it as resolved. Now, if they document it as resolving or improving or stable, those are all further defining terms that it is still being treated. Okay, so number of problems addressed. A little bit further into this, let's go into the different elements. So you have a minimal problem, a problem that may not require the presence of a physician or other qualified healthcare professional, but the service is provided under the physician or other qualified healthcare professional supervision, i.e. what we discussed earlier, which is your 99211 or your 99281, for example. So these do not require your provider to see the patient face to face. This could be like a blood pressure check. This could be just they're coming in for an injection, something like that. Self-limited or a minor problem. This is a problem that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. So, that could be a sinus infection, or, acute bronchitis, or a urinary tract infection, something where they're going to prescribe a medication. And once they finish that antibiotic or whatever they're prescribing, the patient will recover, and ultimately it will not be affected in their permanent health status. Within this column, the problems are categorized in the following elements. So you have acute, chronic, undiagnosed, and these categories apply to all types and places of service. So this is a really good visual for chronic problems. So as we mentioned earlier, straightforward is minimally used, but can be used if needed. You have a stable chronic problem, whether it be new or established, initial or subsequent, and this is going to be your low risk. As you can see by the visual, it gives you all of the codes that could possibly qualify as a low risk. Okay, you have your moderate risk and your levels. Then you have your high risk levels. But the main thing to pay attention to here is the increased risk, the risk of morbidity and mortality. If this patient is not treated for this issue, are they going to recover, or are they only going to get worse or possibly pass away if not treated within a certain period of time? Okay, so let's get a little further into low complexity. So a stable chronic illness. So this is a problem that's expected duration is at least 1 year or until death of the patient. Okay, so as long as they have it for the rest of their life and they're being treated for it, it will continue to be a chronic illness. For the purpose of defining a chronic condition, they are treated whether or not the stage or severity changes. For example, say uncontrolled diabetes or controlled diabetes, it's still the same chronic condition. There is not a separate diagnosis for uncontrolled or controlled. It's treated the same as far as the chronic condition. Stable, for purposes of categorizing medical decision making, is defined by the specific treatment goals for an individual patient. So if they're stable on a medication, the provider's not increasing it, changing it, having to order labs or other tests to find out, why it has not gotten better, or at least staying the same. A patient who is not at his or her treatment goal is not stable, even if the condition has not changed and there is no short-term threat to life or function. For example, a patient with persistently poorly controlled blood pressure, for whom better control is a goal, is not stable. Even if the pressures are not changing and the patient is asymptomatic, the risk of morbidity without treatment is significant. Now we have moderate complexity. So this is a chronic illness that is exacerbated. It is progressively getting worse, or having side effects of treatment. A chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control progression and requiring additional supportive care, or requiring attention to a treatment for the side effects. So this was a revision from the 2021 guidelines, the deletion of the phrase, but that does not require consideration of hospital level care. So that's just a side note for you to have. So now we have our high complexity. This is going to be the highest levels that you can bill, because these are going to be your sickest patients. So it's a chronic illness with severe exacerbation, progression, or side effects of treatment. The severe exacerbation or progression of a chronic illness or severe side effects of treatment that may have significant risk of morbidity and may require escalation in level of care. And again, it was revised, deleting the phrase "and may require hospital level care." So let's talk about issues with column 2. So you have column 1 and column 3 that have no scoring. Rather, a review of the column for the highest level of complexity is made. In contrast, column 2 requires scoring. Therefore, this column contains 3 different categories, each of which are comprised of work components. So this is your data column. This is where they're going to be running lab tests or radiology tests, those type of things. Each record is reviewed and the work components are tallied within this column to finalize the overall complexity of column 2 or the overall complexity of the data addressed. So category 1, which are your tests and documents. According to the AMA 2021 documentation guidelines, this category is labeled as tests and documents. More appropriately, it could probably be labeled as work commonly performed in an encounter. What we find in this category includes review of notes, ordering and reviewing of tests, and the assessment requiring an independent historian, although this is sometimes credited to category 2, and we'll talk about that a little bit later. Common occurrences during the average encounter. So basically, if you come in with specific symptoms, the provider is going to run a designated line of tests. So if you come in with urinary retention or pain when urinating, they're going to want you to do a urinalysis, and there may be other specific blood tests they might want to run on you. So just know that those are going to be the things you're going to see your provider documenting with specific symptoms the patient is coming in with. And that can go for several things. Acute bronchitis, if they think the patient's coming in with, a cough and wheezing and this type of thing, shortness of breath, they may want to do a chest x-ray. Okay, so those are what they mean by common occurrences during the average encounter. Okay, so further into category 1, any combination of 2 from the following, which includes review of prior external notes from each unique source, review of the results of each unique test, or ordering each unique test. Okay, so let's get a little further into review of external notes. An external physician or other qualified healthcare professional, which is an external physician or other qualified healthcare professional who is not, the key is they're not in the same group practice or is of a different specialty or subspecialty. This can include licensed professionals who are practicing independently. The individual may also be a facility or organization, such as a hospital, nursing facility, or home health agency. So we want to do a combination of data elements, a combination of different data elements for each example, a combination of notes reviewed, tests ordered, test reviewed, or an independent historian allows these elements to be summed, and it does not require each item or type to be represented. A unique test ordered plus a note reviewed and an independent historian would be a combination of these 3 elements. For example, the doctor cardiologist is seeing Dan Murphy for uncontrolled hypertension. Dr. Cardiologist reviews a previous admission with 46 pages that includes admission notes, labs, EKGs, echo, and stress tests. In this example, the provider would receive credit for this one component of work within category 1 of column 2. Okay, review of results for each test. Ordering a test is included in the category of test results, and the review of the test result is part of the encounter and not for a subsequent encounter. Okay, they cannot double dip, they cannot get counted for that twice. Ordering a test may include those considered but not selected after shared decision making. For example, a patient may request a diagnostic imaging that is not necessary for the condition and discussion of the lack of benefit may be required. Alternately, a test may normally be performed, but due to the risk of a specific patient, it is not ordered. These considerations must be documented. So, if a patient has chronic kidney disease, they're probably not going to order a test that has contrast because of the effect on the patient's kidneys. Okay, so let's go a little bit deeper into our review of the results. So there's analyze. This is the process of using the data as part of medical decision making. The data element itself may not be subject to analysis, for example, glucose, but it instead include the thought process for the diagnosis, evaluation, and treatment of the patient. Test orders are presumed to be analyzed when the results are reported. Therefore, when they are ordered during an encounter, they are counted in that encounter. Tests that are ordered outside of the encounter may be counted in this encounter of which they are analyzed. In the case of reoccurring orders, each new result may be counted in the encounter for which it's analyzed. That means today he'll get credit for ordering the test, and he'll get credit for analyzing it whenever the results come back and he sees the patient again for follow-up. For example, an encounter includes an order for monthly um, um, prothrombin times, which would count for one prothrombin time ordered and reviewed. Additional future results, if analyzed in a subsequent encounter, may be counted as a single test in that subsequent encounter. Any service for which the professional component is separately reported by the physician or other qualified healthcare professional reporting the E&M service, it is not counted as a data element ordered, reviewed, analyzed, or independently interpreted for the purposes of determining the level of medical decision making, because that's what we call double dipping. They cannot get credit for the medical decision making and then bill for the service on top of it. Okay, let's talk about independent historian. So at the low level of complexity, this component is rated as a category 2, but once we move to moderate and high, it shifts to category 1. However, the concept and guidelines do not change. An independent historian is an individual, such as the parent, guardian, surrogate, spouse, or witness, that is providing the history in addition to the history provided by the patient who is unable to provide a complete or reliable history. This could be due to a developmental stage, it could be due to dementia, psychosis, um, if they're in a coma, whatever the case may be. Um, but the main takeaway here is they are also getting history from another source. It's not coming from the patient. In this case, this may conflict with poor communication between multiple historians, and more than one historian may be needed. The independent historian requirement is met. Okay, and I put this in bold just so everyone has a nice reminder that translation services are not included in independent historian. Um, Legally, hospitals are required to provide translation services for patients that do not speak English. So therefore, you cannot get credit for the independent historian. Okay, let's talk about category 2. Independent interpretation. So this is the interpretation for a test that is interpretation or report that is customary. This does not apply when the physician or qualified healthcare professional reports the E&M service that is previously reported for this test. Okay, this means that another doctor did this test, interpreted this test, and this provider is reading that scan, those films, and they are coming up with their own interpretation. They are not just reading whatever that other provider interpreted. Okay, category 3, discussion. So discussion requires interactive exchange. The exchange must be direct and is not through intermediaries, meaning clinical staff or trainees. Sending chart notes or written exchanges that are within progress notes does not qualify as a interactive exchange. The discussion does not need to be on the date of the encounter, but it is counted only once and only when it is used in the medical decision making of that encounter. It may be asynchronous, which is it does not need to be in person, but it must be initiated and completed within a short period of time, within a day or two, for example. Okay, so let's talk about risk of complications, morbidity, and mortality for patient management. So this is going to be your last column in the medical decision-making chart. So risk is the probability and or consequences of an event. The assessment or level of risk is affected by the nature of the event under consideration. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may be low risk. Definitions of risk are based upon the usual behavior and thought process of a physician or other qualified healthcare professional in the same specialty. Trained clinicians apply common language usage meanings to terms such as high, medium, low, or minimal risk and do not require quantification for these definitions. For the purpose of MDM, the level of risk is based upon the consequences of the problem addressed at the encounter when they are appropriately treated. Risk also includes the MDM related to the need to initiate or forego further testing, treatment, or hospitalization. The risk of patient management criteria applies to patient management decisions made by the reporting physician or other qualified healthcare professional as part of the reported encounter. So, over the last few years, social determinants of health have become a very important part, especially in inpatient or observation settings, because in a lot of times these patients are coming in homeless, they're found, out on the street, or if it's an elderly person and they don't have any way to go pick up their medicines because they don't have family, they don't have a means of driving to get them, or if it's a low income family and they just can't afford the medication, those are all considered social determinants of health. Okay. So let's break it down. Minimal risk. This is going to be, for example, on the new side and the established side. So you have your 99202 and your 99212. These examples for minimal risk would include recommending rest, gargles, elastic bandages, or superficial dressings. Each one of these options are self-performed and even self-prescribed treatments for the patient. Therefore, they are minimal risk. Low risk diagnostic testing can include over the counter medications like Advil, Tylenol, Benadryl, things of that nature. Minor surgery that include procedures in the office with no identified risk. So, they removed skin tags or something of that nature. Physical therapy and occupational therapy. Moderate risk really rises the level where we are talking about um, more higher risk things to the patient. So when we consider moderate risk and the fact that this also is representative of a level 4, we often in our minds associate this with being more intense service. However, interestingly enough, we skip over the words use and rather focus on the placement of the service. Moderate means average in the amount of intensity, quality, or degree. Even more interesting are synonyms we could use to substitute for moderate. And we would keep the definition the same, but make sure if you are an auditor, you're looking at this quite differently. So let's consider the following statements. Okay, this is in regards to moderate risk, average risk of morbidity, modest risk of morbidity, medium, ordinary, common, everyday, mild, neutral. Okay. When you consider some of these terms as opposed to moderate, the clinical mindset of moderate level would be more relevant to encounters that make more sense. Now, keep in mind, this is only one of the three columns, and it takes two of the three to be able to assign your level of medical decision making. So let's apply this to common examples of treatment or management options. And this is based on the 2021 documentation guidelines. Okay. Um, so let's look at these components: prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors. That means the doctor told you what the risk to the patient or the risk of the procedure is, documented in that note. Decision regarding elective major surgery, and this is without identified patient or procedure risk factors. And then we have the diagnosis or treatment significantly limited by social determinants of health. Let's dive a little further into prescription drug management. Prescription drug management is the initiation, continuation, discontinuation, or modification of any prescription medication. This does not include medications that are over the counter and prescription that are only prescribed for insurance benefits. Keep in mind that the patient's convenience and reimbursement rules never make such determinations. A key word in the description that causes confusion is the word management. Oftentimes, coders and auditors hear the word management and infer that this would mean long time use, or they have to look up the definition of this word. But really, there's two keys to determine RX management. Did it require prescriptive authority, meaning the doctor has to write you a prescription for that medication? You take it to the pharmacy and you get it filled. Is the provider of record managing the RX, meaning your doctor could address a medication you're on, but if the cardiologist is the one managing that medication, your doctor that you're seeing that is not managing that medication cannot get credit for prescription drug management if they are not the one managing it. Okay, now let's get into high risk. This category is the highest form of treatment and management documented. And as noted in the levels of complexity based on the 2021 documentation guidelines, we have a few examples. So, drug therapy requiring intensive monitoring for toxicity. This could be a heparin drip. This could be a Zosyn antibiotic. This could be amiodarone for AFib. Okay, there are many different types, but remember that it has to be monitored. That means they need to be doing blood work or other forms of testing to make sure that the patient is not going to have a toxic effect. Decision regarding elective major surgery, and this is with identified patient or procedure risk factors. Decision regarding emergency major surgery. And in that case, they don't have to talk about risk factors because it's emergent. That means they got to get them in to the OR as soon as possible. This also includes decision regarding hospitalization. So that could be they're deciding to admit the patient to an inpatient level within the hospital. And then there's decision not to resuscitate or to de-escalate care because of poor prognosis. If the provider has a discussion with the family and they choose to put the patient on palliative care, or they discharge the patient, and they are only being under a minimal care because the prognosis is inevitably death of the patient. Drug therapy requiring monitoring. So this is just going a little bit deeper into the definition for requiring intensive monitoring. So you really have to think about what are the adverse effects? What happens if the patient gets too much of this drug, too little of this drug? They have to be consistently monitoring it through a laboratory test, a physiological test, or in imaging, and this must be documented in the note. Okay, remember that in the office setting, drug therapy requiring monitoring does not mean that once a year lab work or that every 6 months lab work. This is continuous monitoring, like in the hospital when they're having lab work done regularly during their stay. Okay. Here is a little bit further into our elective, major, or emergency surgery. Remember that elective means that they're discussing it with the patient and they're talking about the risk to the patient. They're talking about the risk of the procedure, and the patient's deciding on their own or electively that they do or do not want to have this procedure. Now, on the other hand, you have emergency, which means they come into the hospital or they have to be admitted straight from the office because they need to have that surgery immediately, or it could have a high morbidity or mortality rate that the possibility of them passing away is very high. Decision for hospitalization or escalation of care. I talked about this a minute ago. This is making that decision to escalate the patient's treatment. So they're in the ER or an observation level. The provider sees them and escalates to inpatient level. Decision not to resuscitate due to poor prognosis. So remember that this is not advanced care planning. This is active discussions due to poor prognosis that make the encounter high risk. Having a conversation about end of life planning is not high risk. Omitting further intervention for a patient is high risk. Okay, so now we have covered our medical decision-making portion. Now we're going to move on to time-based evaluation and management services. So time is not a descriptive component for the emergency department. So your codes 99281 through 99285, you cannot use time to level those codes. They are only based on medical decision making. Okay, so in previous years, evaluation and management services had a range of time. And when they updated the guidelines, they made it to where it has to be met or exceeded. And I have a couple visuals of that further on into the presentation. Okay, so remember that it includes both face-to-face time with the patient and or family or caregiver, and your non-face-to-face time personally spent by the physician or other qualified healthcare professional on the day of the encounter. That includes activities that require the physician or the other qualified healthcare professional, and it does not include activities performed by other clinical staff. And I put this in big letters here. It does not include any time spent in the performance of any separately reportable service. So if a provider is billing for that separate procedure, they cannot include that in the time for the evaluation and management service. Okay, so let's talk about our qualifying statement. When time is being used to report an office visit, the documentation should include sufficient information to support the amount of time reported. This would include a description of the activities personally performed by the provider on the date of that face-to-face visit. It is not enough for your provider to merely state that XX time was spent. So they spent 60 minutes, they spent 20 minutes. They need to tell you what they were doing during that time frame. They need to give you a description, and it needs to be in greater detail than simply telling you how much time they spent. So the items that are included in the qualifying statement. So you have preparing to see the patient, obtaining and reviewing separately obtained history, performing the exam or the evaluation, counseling and educating, ordering medications, tests, procedures, referring to other providers, communicating with other QHPs, independently interpreting results, care coordination that they are not separately reporting. So these are all elements that go into the final time that they've spent for this patient. So let's look at our chart we have here. So for a new patient office visit, you have 99201 through 99205. As you can see, 2021, they deleted the 99201 and they updated the 99211 to remove time. Now, for your 202 through your 205, you've got your ranges, your 15 to 29, 30 to 44, 45 to 59, and 60 to 74. For your 212 through your 215, you've got your 10 to 19, 20 to 29, 30 to 39, and 40 to 54 minutes. Now you have your office or outpatient consults, and this is going to be your 99242 through your 99245. Remember, the 4 means outpatient, and if you're billing inpatient consults, that would be a 5. So it would be 99252 through 99255. And as you can see, this is total time on the day of the visit, 20 minutes, 30, 40, and 55. And also, as a side note, Medicare does not pay for these. You would fall back to your new or established evaluation and management service codes and not bill consults to Medicare or any Medicare plan that follows Medicare guidelines. So your hospital inpatient or observation care services. Remember when they updated the guidelines, they included observation care, and then they removed the observation, evaluation, and management services that used to be a separate set of codes. Now, as you can see, this is the update I was telling you about, is 99211 through 223. These are your initials. Then you have your 231 through 233, which is your subsequent levels. And you have to meet or exceed the minimal time. It's not a range. You have to at least get that 40 minutes for a 221, or for a 233, you have to get at least 50 minutes. For inpatient or observation consult codes, remember I was mentioning a minute ago, for inpatient, you have the 25 codes. And again, these are not covered by Medicare, so you're going to fall back to your initial or subsequent inpatient codes. I hope everyone enjoyed this presentation on medical decision making versus time when choosing evaluation and management services. Here are my references, which is the 2024 AMA CPT book. And I've also included the link to the AMA website for the additional information on these guidelines. thank you so much for listening today, and feel free to reach out to me via the Facebook group, the Coding Corner. Subscribe and follow me for more videos. Thank you.